Hello, everyone, and welcome to today's episode of Office Hours. I'm Stuart Newsom, and I'm very excited to have you join us for a very important discussion on telehealth compliance with AI and cardiology. As we all know, telehealth continues to evolve very rapidly with new regulations and coding changes impacting practices significantly. So today we'll explore how cardiology providers can navigate these updates, address compliance challenges, and explore the potential of AI and automation to enhance their workflows. Now, I'm thrilled as always to introduce our guest. She likely doesn't need any introduction. She's been on Office Hours many times. It's Julie Graham, our Senior Coding Manager here at Infinix, and is an expert in healthcare documentation and compliance. So Julie will share her insights on the regulatory changes and the challenges facing cardiology practice today. We'll also provide commentary on how AI and automation might help address these challenges, with Julie offering her perspective on the viability of these solutions. So how you doing today, Julie?
I'm doing great. Thank you, Stuart.
Um, well, we'll dive right into this. Just kind of a quick roadmap of what our conversation is going to be like today. First, we're going to begin by understanding the recent telehealth regulation changes, particularly how they impact cardiology. Then we'll also explore the compliance and documentation challenges that these changes will be bringing. And then finally, we're going to discuss how AI and automation can assist in addressing these challenges. Again, we're going to have a lot of feedback from Julie. I'll have some comments and commentary as well on the feasibility, the practicability, the adoptability, if you will, of use of AI within this environment. And like always, don't forget, we'll have a Q&A session at the very end of the webinar. So please submit your questions in the chat as we go along, and we'll be happy to answer them as able. So with that, Julie, I'm going to dive right in. First question I want to ask you is maybe a softball kind of a question, but what are the most significant telehealth regulation challenges that cardiology practices need to be aware of this year?
Well, the AMA created new telehealth codes for audio, video, audio only, and virtual check-in, which is also known as a brief communication code. And so we have these new codes for new patient. They're broken down between audio, video, new patient codes, and established patient codes. So those new patient codes are going to be your 98000 through 98003. And your established care patients for audio, video are going to be your 98004 through 98007. We also have audio only codes, and those are also broken down by new patient versus established patient. And so those are for the new patient 98008 through 98011. And for our established patients, it will be 98012 through 98015. Now for that virtual check-in code, that's going to be your 98016. And then the other big change is that, CPT has deleted those telephone codes, the 99441 through 99443. So if you look in your CPT code book from 2024 to 2025, those codes will no longer be available in the 2025 book. And so one of the challenges that we're dealing with right now is that practitioners should not bill Medicare using these new codes, using those new telehealth codes 98000 through 98015. And this is because CMS has determined it will not provide reimbursement for these codes because they felt that they were in effect duplicative of existing codes. And they've labeled them as a invalid status, which means there will be no reimbursement for those codes. And to add another layer of challenge is that at this time, we just, at least from my research, we don't know what private payers are going to do with these codes. I've been scouring, looking at Aetna, Cigna, Blue Cross, Blue Shield, trying to find out what their stance is on these codes. Do they have policies for these codes? Will they cover these codes? And to date, I haven't found anything giving any direction on these codes. So we just don't know if they're going to follow Medicare guidelines. I kind of think that they will, just as
Mhm.
a you know, they follow Medicare guidelines on a lot of things, and I think this is just kind of an opportunity for them to um, say, hey, you know, we don't want to pay for these codes either. We're going to go ahead and follow Medicare guidelines on this, but that's
Mhm.
just really yet to be seen.
Yeah, I know. I've typically seen that they about 90% of the time they either follow the Medicare guidelines or adapt, the majority of what the guidelines say, for Medicare. And I just want to add a little commentary here as well, and ask a follow-up question to this. And this is really, I mean, a lot of practices who are heavy in Medicare or do some Medicare billing are probably going to look back and go, okay, well then what do we do? What guidance do we have? What guidance does Medicare have? In a way, it kind of makes sense because I know, again, COVID, all things point back to COVID, really changed a lot regarding the use of E&M codes. How did it be utilized? It may just be, and I want your opinion on this, but it seems like they're maybe taking a stance of, hey, we already have these E&M codes, for instance, like this, with place of service indicators, with modifiers that can be utilized. Uh, maybe it seems duplicative, if so to speak.
Yeah, that was their stance. And so, yeah, for Medicare patients, you're going to continue to bill just as you did, you know, since the PHE started. You're going to, you know, and even
Mhm.
after it was ended, you're going to bill those regular E&M codes, you know, your 99211 through 99205. You're going to
Mhm.
use that place of service 2 or 10. And you're going to bill with the modifier 95. That's so that hasn't changed. That makes it easy. And you know, one thing that they did adopt, and I meant to bring this up, is they are going ahead and covering the 98016. I believe that replaced code G 2012, if I'm not
Mhm.
mistaken. So there will be reimbursement for 98016. Now, there have been a couple of clients of mine that have asked, you know, can we use this brief communication, this virtual check-in code for a telephone call? But you cannot.
Mhm.
That's not what it's meant for. And if you read the guidelines, they're pretty specific. It actually has to be for an established patient only, and it has to be a patient initiated code. So
Mhm.
that's something to keep in mind. There's a lot more guidelines that I can't get into all of those today, but
Right.
that's two things
Right.
you should know about the 98016. It needs to be patient initiated.
That's good. That's good. Because and it does make sense, being for established patients only, because you think about it. If you have a new patient, you really need to see them in person.
Oh yeah, for sure.
Yeah. Some of these are just common sense. But yeah, so with these changes, obviously big impact. So
Yeah.
how are they impacting cardiology providers in terms of
Well,
coding, billing, compliance? They may already have an infrastructure that they may have to change.
well, you know, uncertainty on coverage policies for private payers with the new telehealth codes. You know, can you bill them? Can you not? Um, you know, you may try to bill them and track them and see what happens, but there's just uncertainty there. So if you have an Aetna patient, you're like, do I bill like I used to bill for telehealth, or do I bill these new telehealth codes? You know, there's just that uncertainty there. And then again, will Medicare or will these private payers follow Medicare guidelines, or will they allow the new telehealth codes to be reported and reimbursed? So this will require staying up to date with these payer policy or with these payer specific changes and remaining compliant within those guidelines. I do know for a fact that United Healthcare's telehealth eligible services code list does not list the new codes. So and that was updated in the copyright markers for 2025 on that. And when you look at that, it still shows your 99211 through 99205. Your subsequent visits or you know, the 99231 through 233, your consult codes, 99221 through 99223, but these new codes are not on that list. So UHC is the only one that I've been able to determine that they're not going to cover the new telehealth codes.
Hmm.
The other thing that I think of is that the removal of the telephone codes may disproportionately impact physicians serving rural or underserved areas where internet access for video visits is limited. And for these patients, phone consultations were often the only viable option. And so, without the reimbursement option for these telephone services, physicians in these areas, or even outside of those in large metropolitan areas, may face challenges in maintaining accessibility for their patients, potentially leading to care gaps or financial losses for the practice. Um, yeah. So
Yeah.
that's how it will, and that impacts coding, so it impacts the bottom line. You've got to stay compliant. You've got to know those compliance rules. So it's just an all-encompassing kind of perfect storm right now.
Wow. Yes. So what are some of the most common documentation errors you've seen in telehealth claims,
Uh,
and how can practices, address them?
yeah. So missing documentation of a visit performed by audio, video, and patient consent. I've seen a lot of, these visits being billed as a telehealth visit, with your 99213 or 214 with that correct place of service and that 95 modifier. But when I review the documentation, it clearly states that the visit was performed by telephone. There's no audio, no synchronous audio video component. And some of them are missing the statement of patient consent. Those still apply. You still have to have patient consent to perform those services. And so that's some of the opportunities I've seen for providers to make sure they stay compliant if they were to be audited, and prevent a recoupment of that money.
Hmm.
Um, And then so you have to ensure you follow these telehealth guidelines by, I think the best way to do this is by establishing a telehealth policy, having your compliance department. If you don't have a specific compliance department, maybe you're a smaller practice, you talk to your coding manager, or a coder, somebody that can help you understand those guidelines and make sure that you're staying compliant, and maybe what you would do in certain scenarios or circumstances. Like, for example, let's say you start a visit via audio video and it falls short, and you can only, the audio goes out or something like that. So you can only complete it by telephone at that point. What are you going to do? What are your options? And how can
Hmm.
you stay compliant within that scenario? Um, and then also just making sure that you have the correct code choice, the correct modifiers, and know which circumstances support that telehealth coding. And then I've kind of already mentioned this, but make sure you're not using that 98016 in place of the 99441 through 99443.
Right, right. And so, and looking at this, kind of shifting to how AI can play a role in preventing these errors, particularly in documentation, flagging discrepancies um, between recorded encounters and billing codes. I know AI-powered tools are already capable of analyzing clinical notes and billing codes in real time, ensuring that they match appropriately and flagging discrepancies. I know the payers are doing this.
Yeah,
The payers
great
have
point.
AI in place where they're reading clinical notes and matching to the billing codes. And I think we've already had an episode in the past about how they're utilizing that for recoupments.
Yeah,
Um, but
absolutely.
just want to understand, kind of, do you think that's feasible, you know, for in those for those tasks to be automated to help, capture those discrepancies?
Yeah, absolutely. For example, one of the most common issues in telehealth claims is mismatch of documentation, such as when the encounter is coded as a video-based telehealth visit, but the notes reflect only that it was an audio video interaction. So the AI tools will equip equipped with natural language processing or NLP can scan these notes, detect these inconsistencies, and alert billing teams before
Hmm.
submission. And this reduces the risk of claims being denied and saves time on rework.
Right. And that's such a critical component. I think that you just reminded me when you made that statement that AI is not necessarily doing the work for you. It can. I mean, but in
Yeah.
this instance, it's actually flagging. Wait a minute, there's something wrong with this documentation. It's not correcting that documentation because that's a no-no. Only a provider can correct the documentation. But it's also not coding or correcting the coding. It's just merely where it's going to give an alert that, hey, someone needs to take a look at this before the claim goes out and make sure it's coded appropriately. And I
Yeah.
think that's a smart use where it's just bringing, something to the forefront where someone can catch it and then correct that error.
Right. And it also provides, you know, when you're catching those documentation insufficiencies, that gives you an opportunity for provider education. Maybe they didn't know
Mhm.
that, or maybe they forgot. And so it's a twofold win. You know, you educate your providers, and then number two, you prevent claims from going out and just automatically being denied, or, you know, setting a practice up for a an audit on these. It just it
Mhm.
protects you from a client compliance perspective and financial perspective.
Sure, sure. And of course, there's another one I think is always centered around patient consent.
Yes.
And you got to have that documented as well. So automation can help streamline this process as well, verifying telehealth compliant, such as patient consent, whether it's properly documented, and the visits align with those requirements. So I know automation tools can simplify telehealth compliance, verifying elements like this, such as patient consent, before the claims even go out the door. Once again, so Julie, what do you think about the feasibility of automating that task?
Yeah, I mean, verifying compliance manually is tedious and prone to human error, particularly when it involves large volumes of claims. And so robotic process automation, or RPA, can take over repetitive tasks, such as confirming the patient consent for telehealth services is properly documented and that the visit aligns with regulatory requirements. By automating these checks, practices can ensure compliance without overburdening their staff, which ultimately frees up time to focus on other things and provide better patient care.
Right, right, exactly. So, I mean, there's all kind of applications here for AI and automation. We could go on and on. Probably have a whole nother episode on that. But looking ahead, AI could evolve. It has evolved. AI has severely improved. I mean, AI has been around. I think the term AI was first coined back in the early 50s, believe it or not. And so
Yeah,
AI has been a part of our world ever since, and it has been evolving over time, but particularly in better supporting cardiology providers and managing telehealth compliance. And we've given two examples already of that. It has the potential of also integrating seamlessly in the EHR across platforms in the form of agents. So there's a big buzz going around now about AI agents and the offerings that they bring to the table in helping. So these agents could give real-time guidance to physicians during documentation, right?
yeah.
So, Julie, based on what we've discussed so far, and you and I have had some discussions kind of off webinar, so to speak, but what areas of coding or documentation would benefit most from future AI advancements, particularly utilizing, say an AI agent? You have a little agent sitting there telling you, hey, you ought to do it this way.
So, you know, in the future, AI could evolve to act as a real time assistant for providers. For instance, while a physician is documenting a telehealth visit, the AI agent could prompt them to include missing details or suggest the correct coding for the encounter based on information provided. Additionally, AI could adapt quickly to regulatory changes, automatically updating compliance guidelines within the system without requiring significant manual intervention.
Yeah, exactly. And so and kind of adding that, you have to be very careful. At least EHRs in particular have to be very careful. So I'm just going to use an example of E&M coding. And I could just see someone saying, well, can an agent tell me from an E&M perspective what elements I need to bump this up to 99214 from a 99213, right? And so that would be a big compliance problem because you never
Oh, yeah.
want to. Now, if it's there, if it's telling you, hey, you missed this, but then that same AI agent could actually say the code is a 99213, but the agent shouldn't say, oh, by the way, if you had one more lab, if you did one more, um, diagnosis and that was more severe than say this diagnosis, you could probably get a 99214. So I think we need to keep an eye on that from an agent standpoint because from a compliance standpoint, it's still the provider that's responsible. You can't blame
Yeah.
the agent. Say, oh, the agent made me do it. So you definitely have to be sure that it still has those compliance parameters. So shouldn't be used to encourage upcoding. And that's just a mere example. There are many other scenarios out there, I'm sure, to where, just kind of rein them in, but they're also going to be very effective in making sure, because all I hear all day long is, providers' time and efforts, as well as the staff time and efforts. How can we automate this and bring in, I'd like to call digital delegation, so to speak, into the fold. All right. Well, now we're going to turn it over to some Q&A. So if you have any questions, I still want to make sure that you put in your questions in that Q&A box, and Julie and I will answer them to the best of our ability today. If we don't know the answer, we'll find out and get that answer to you pronto. But we do have one question here that reads, what are some ways that AI can proactively identify and resolve compliance risks, such as the improper use of a telehealth modifier? That's an
Good
interesting
question.
one. Yeah, so I would say probably thinking about that, just like we talked about how it could flag and catch things. I'm sure AI can predict compliance risk and highlight claims that are likely to face denials or audits before they're submitted. So it could likely, flag that. So Julie, do you think this would be helpful for cardiology practices? What's your take on that?
Oh, yeah, for sure. Imagine having a tool that identifies potential red flags in your claims, like overuse of a certain telehealth or overuse of certain telehealth codes, or inconsistencies in modifier usage, um, before before they even leave your system. So before it even goes to the insurance company, it's like a little safeguard, a little safety net. And then, the predictive analysis allows AI to monitor patterns and alert your teams to risks, giving you the chance to correct errors proactively. This not only reduces financial losses, but also helps to maintain a strong compliance record.
Oh, awesome, awesome.
Yeah.
Well, and I'm looking in, I really don't see any other questions from the audience. So without further ado, that could be a wrap, unless you have any questions you've heard from people in the past that you've encountered, some of our prospects or some of our clients that have questions about this change.
Yeah, the biggest question I'm getting right now is, in regards to the telephone codes. These clients had large utilization of, the telephone codes 99441 through 99443. These are just um, a nice benefit for the older population that may not be as good with with technology. And so their questions have been, now that Medicare has, well, now that the AMA has eliminated these codes, we have these new audio only codes, but Medicare is not covering them. What do we do in this instance? What options do we have? So for Medicare patients, there's not a whole lot of options out there. It's really unfortunate that Medicare didn't choose to even at least cover the audio only new codes, the 98008 through 98015. But, there is a little caveat where Medicare if it's properly documented, you know, if a patient absolutely refuses to be on camera, or if they're just struggling with the technology for the video, they don't know
Mhm.
how to work it, they're unsure of what they can use or how to apply that, and they prefer to do it by telephone. As long as that's documented, Medicare will accept that, but they don't want it to be abused.
Mhm.
So it needs to be well documented. But right now, that's really your only recourse for those Medicare patients. And like I said earlier, with private payers, we really are just waiting to see what they're going to do. I have been in some other webinars on my own, which there's been a suggestion to either hold those claims until you figure out if private payers are going to pay or not, or just bill the private payers. I don't really suggest holding claims. You risk the chance of those hitting timely filing or missing out on some
Mhm.
reimbursement. You could, however, bill these new codes to private payers and just track those claims, see what they're doing, see what they say, see what's happening. But I just continue to keep on looking online to see if there's any updates to those. And so that's really all we can do right now until we get more direction.
Nice, nice. Well, that wraps up this episode of Office Hours. I want to thank you, Julie, as always, for coming on board. You always have helpful insights, keeping us up to date on what the regulations are, making sure everyone's in line with those. So that's excellent advice. I know telehealth has always been a confusing part of coding and documentation and claims. It was before COVID. It certainly was during COVID and then here after COVID, what's going on. So helping us
Well,
to, yeah, maneuver through all that has been very helpful.
and we also have to remember, and I should have stated this earlier, you know, these extensions for telehealth by Congress are only good until March 31st. So we have to wait
Mm.
for this new administration to see if they're going to extend it again. And that'll be a whole nother topic for another time.
Right, right. So one thing that we can be certain of, there will be change, even
Yes, it's
though, even
constant.
though, even though everything stays the same.
Yes.
So, well, I want to thank everyone else for joining us today. We really appreciate our audience. Be sure that you stay tuned for next week's office hours. It's going to be a very exciting subject. Can't wait to see you then. Thanks, everyone.